So now that we've got that information from the patient, we're thinking, okay, the patient sat bolt upright, we're going to change that a little bit, educate them. We're going to slow down their rate of speech, which again, a nice way that I like to do that is to get the patient breathing through their nose. Okay, so again, when I'm talking to the patient, I'll ask the patient to keep their lips together, tongue on the roof of their mouth, just behind their teeth, where you say na, 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 so where your tongue hits the roof of your mouth, teeth slightly apart, and you're just going to breathe through your nose. Now that's a nice way just to get the person back into rest and digest, because again, we're breathing through our nose, so we're slowing the breathing rate down, we're adding variability, which is going to impact our heart rate variability also. Okay, so that's a nice kind of tip that you can give the patient while they're sat there listening to you as well, to slow their breathing rate and get them back into rest and digest. Okay, so with that said, quite a lot of information in this video. It might be worth going back, rewatching this video, make some more notes. But now that you're comfortable with that, or when you're comfortable with that, let's move on to the next video and we look at the objective assessment and picking out some clues that the diaphragm and pelvic floor may be involved in our traditional assessments that you're probably doing on a day-to-day basis. So for the subjective assessment, we're going to use the toe touch, the backward bend, side flexion, and rotation. Now, I like these 4 movements because it gives us a really good indication of how a person is working around or having a movement strategy around maybe their previous injuries or non-physical stressors. So the nice thing about the toe touch is that we're looking at rib cage mobility. So when I ask Craig to touch his toes in a second now, the first thing he's going to need to do is reach with his fingertips. Okay, so movement, we always have intent that's usually leading with our hand or with our foot. Okay, so if I say to Craig, touch his toes are down here. Okay, so my toes are down here. So what you see with a lot of patients, and Craig, I haven't assessed Craig yet, I haven't seen him move yet. So I'm going to be looking at him for the first time, which I think is actually good for this video, so I can kind of show you what I'm looking for and what I'm seeing. But for a lot of patients with persistent pain especially, or osteitis pubis or something like that, that don't have a lot of ribcage mobility, they'll go to touch their toes and they'll start with their intent by reaching out here, okay? So when I reach out here, I'm not getting a lot of ribcage mobility, okay? So, or said another way, I'm not getting a lot of ribcage retraction. Okay, when I get a lot of ribcage retraction, I get a lot of lengthening through the diaphragm. So if that patient's not happy to retract the ribcage and lengthen the diaphragm as I go to touch my toes, very often you'll see them go to touch their toes out here. Whereas what we want is we want an efficient movement where your toes are there, let's just touch your toes. Now, in order for that to happen, we need protraction of the scapula, we need good mobility through the upper ribcage, which we're going to look at passively in a minute in the next video, and then we want the diaphragm to lengthen as I go down to touch my toes, okay? So I can actually go to touch my toes and I can get my knees, or I can get my hands past my knees with very, very little movement happening at the lumbar spine, okay? Or said another way, without a lot of deceleration happening at the lumbar extensors, okay? So the more mobility I have through my rib cage, the less load, so to speak, is being taken by my low back. Okay, now if I can't do that, straight away then I'm going to access my back. My back's going to start working almost concentrically when I go to reach outwards rather than being able to eccentrically lengthen and relax. Okay, now we know from research that at the bottom of the toe touch, we want in healthy individuals, we want their low back muscles to be able to completely relax. What I see a lot with persistent back pain patients and people with osteitis pubis and various other persistent things is that they're not happy for these tissues to even let go in the first place, that they use that extensor strategy. Then they almost overstretch their hamstrings to get down as a compensation. So a lot of these people, they can get their hands down to the floor, they can almost get their palms down to the floor, but what we're not seeing is a whole lot of retraction of the rib cage. Okay, so that's the big clue for me, that we've got a rib cage, we've got a diaphragm, we've got a pelvic floor that may be contributing to this issue.